So that's, kind of where we're at with respect to peritoneal metastases. But when I think about the future, I kind of go back to this paradigm for colon cancer. And I think about where we've been and where we come, especially in particular for liver metastases. So that was a common site of metastases. And I think a lot of work has been done to really improve survival and outcomes for patients with liver metastases. Um, when I think about stage 4 or metastatic colon cancer, when you go back into the 70s and 80s, it was really just supportive care. So it was pain control if you had pain, or nausea medicine if you had nausea. But the survival was probably less than 6 months back at that time. The first chemotherapy that was shown to be, more effective than that was in the 90s. This was called 5-FU and leucovorin that improved survival compared to just supportive care alone. And then, so people kind of started to think, if 5-FU and leucovorin work, what if we added another drug? So Folfox and Folfuri, that's 5-FU and leucovorin. That's the Folf, basically, that's common in both of these. And then the other drug is oxaliplatin or irinotecan. So these are triplet kind of regimens. And that improves survival a little bit more over what it was in the 90s and the kind of the 2000s. And then we developed more and more kind of chemotherapies. So things like targeted therapies and biologic, like bevacizumab or Avastin, or putting all 4 of the drugs together, which is a hard regimen, but continued to kind of push that needle forward. And so as the chemotherapy got better, we had response rates where the liver metastases were getting smaller and smaller, and going from an area of, I think doing surgery is too much and you won't have enough liver left, to now we could potentially take those out. So